going to discuss the genetic barrier to resistance and viral fitness. In this section, we will talk about drugs that have low and high genetic barriers to resistance to HIV. We're going to talk about cross-resistance between drugs and drug classes, and we're going to talk about mutations that result in a change or a decrease in viral fitness. HIV actually acquires resistance to some antiretrovirals very rapidly. So all of the drugs that we use in first line, 3TC, tenofovir, and efavirenz, require a single mutation in order to develop resistance. And we call that a low genetic barrier to resistance. If you gave that drug on its own, the concentration with HIV would drop very rapidly, but over a number of days, it would actually come back up to the baseline level. Other drugs develop resistance a lot more slowly. So drugs like AZT, drugs like lopinavir require an accumulation of mutations in the same virus. So AZT, for example, you need between 4 and 5 thymidine analog mutations in order to develop resistance. And for lopinavir and ritonavir, you need between 8 and 12 resistance mutations in the same virus before you develop resistance. So there you would get a much longer, slower development of resistance over a number of months. And those drugs are said to have a high genetic barrier to resistance. They are more robust and more forgiving in terms of intermittent non-adherence. Once you develop resistance, you can get complete cross-resistance between some drugs. For example, with efavirenz and nevirapine, if you have resistance to efavirenz, having developed the K103N, you will not be able to use nevirapine. You lose both drugs through the resistance that you've developed to one of them. 3TC and FTC, we lose resistance to both of those drugs with the M184V. There are some other drugs where there's partial cross-resistance. For example, people who are taking D4T in first line, when they fail and they have 1 or 2 thymidine analog mutations, you have some resistance to AZT, but usually you can still use that AZT for a while. Between tenofovir and abacavir, there is also some partial cross-resistance. If you have resistance to tenofovir, the effect of abacavir is reduced. And between protease inhibitors, there's also some cross-resistance, particularly if people are allowed to remain on a failing regimen and develop a few protease-resistant mutations, then you undermine the potential for future proteases to help. Another concept that is interesting to understand is that some mutations not only confer resistance to a drug, but also reduce the ability of that virus to replicate. So the M184V mutation, which allows the HIV to be resistant to 3TC, also disables that virus. That virus is less able to replicate, and therefore it's less able to transmit. We can use this in that if you have no further options available to suppress a virus, if you're moving on to pure salvage therapy, you're not trying to suppress anymore, what you try and do is maintain the mutations that disable the virus, and thus you can slow disease progression. This is a slide that illustrates that. The open dots at the top are the rise in viral load, which happens in someone who's failing when you stop their treatment. If you stop their treatment, wild-type virus grows back, it replicates fast, it can damage CD4 cells rapidly, and disease can progress more rapidly. If you leave people on their failing regimen, the viral load does not raise so rapidly. The virus that is there is disabled, it damages CD4s less efficiently, and therefore the disease does not progress so rapidly. Some of these mutations, and again an example is the M184V, also enhance the effect of other drugs. By maintaining the M184V mutation in a population, by continuing 3TC after you have this resistant mutation, that change in configuration of the reverse transcriptase also means that the HIV is going to struggle to develop resistance to AZT, for example. So you maintain a mutation in order to enhance the effect of another drug. So in summary, some antiretrovirals just need a single mutation for resistance, such as tenofovir, 3TC, and efavirenz. Others require an accumulation of drug resistance, such as AZT and Eluvia. And resistance to drugs in one regimen can cause cross-resistance with as yet unused medication. So you need to be aware that you cannot switch from a tenofovir-based regimen to an abacavir-based regimen without knowing what resistance there is to tenofovir there. And in salvage, when you're no longer trying to suppress the virus and all you're trying to do is disable it, some mutations can be useful and can limit further resistance development and decrease viral replication, so slowing down disease progression.